And I'm absolutely delighted to welcome Sinead Walsh and Oliver Johnson to talk about this extraordinary book they've just written about their experiences during the West African Ebola outbreak. Now, there's the connection, and the reason why I'm so excited is the connection with the work of IDS and others in the university during that period, this terrible 2014 to 16 Ebola outbreak period, where many of us at IDS got involved as social scientists, not at the front line, as we'll hear about today, but in trying to help interpret and bring social science, and particularly anthropology, knowledge and advice into the way that the UK and other governments and agencies were formulating their strategies, and tried to help attune the response a bit better to the realities on the ground, and particularly to how women and men in communities in Sierra Leone were experiencing this appalling disease and its fallout. And that was a very interesting and exciting period. We were part of the Scientific Advisory Group on Emergencies and its social science subgroup. We set up and ran this Ebola response anthropology platform. And in the aftermath of the Ebola outbreak, I think many of us are seeing a greater interest in the role of social science and anthropology in helping pandemic preparedness and response in the face of not just further Ebola outbreaks, and we've been carrying on some of the work that we did in the context of the DRC Ebola epidemic that's running rife at the moment, but also in relation to other potential epidemics and pandemics. So we're now running this thing called the Social Science and Humanitarian Action Platform, and have a new big Wellcome Trust Collaborative Award to work in Sierra Leone and Uganda around how communities' own knowledge and perspectives can be part of preparedness efforts. So that's just a little bit of kind of some of what's going on here. But today is about this book and these experiences. So we have here Sinead Walsh, who is currently EU ambassador in South Sudan, but at the time of the West African Ebola outbreak, she was the Irish ambassador to Sierra Leone and to Liberia, and also running Irish Aid, which has a big presence in Sierra Leone, that country. And Oliver Johnson is, I thought, a fully clinically trained doctor. He says he's actually not, but he, at the time, was running a health systems program, the King's College London Connaught Hospital partnership in Sierra Leone, with a real focus on health systems work. He's currently a visiting lecturer at King's College London, and also has a base in South Africa where he's working with Wits University. So we've got two very different perspectives, two very different experiences, which came together, I think, during the Ebola outbreak in ways that we're about to hear. So without further ado, I'll hand over to the two of you.
Thank you very much. Thank you, Melissa. It's great to be here at IDS. I was just saying to Melissa, when I was doing my PhD, I used to come here to grab a few hours here and there with Robert Chambers on his foundational wisdom on issues around accountability and participation. So it's great to be back. As Melissa said, I mean, Oliver and I really were quite accidentally involved in all of this, and then, as I'll tell you what later, we then sort of rather accidentally wrote a book about it. But we were in Sierra Leone for very different reasons. You know, Oliver working on long-term health system strengthening with this small team from King's, and you know, with Irish Aid, I was working on very a lot of issues around nutrition, women and girls' rights, teenage pregnancy, those sorts of issues. And I think one of the things that's maybe important to stress about what happened in the Ebola crisis, and I think it won't really come as a surprise to those of you at IDS, is that of course the crisis happened within contexts that were already sort of hugely challenged with lots of other things. So when I remember the spring of 2014, when the sort of first cases happened in our neighboring country of Guinea, what I remember is really feeling that we were so overwhelmed with Particularly, we were sort of expecting a food security crisis that summer, which has a lot to do with changing climate and harvests and rains and so on. And so we were sort of dealing with the normal emergency rates, because they are emergency rates of child and maternal mortality in Sierra Leone. 1 in 5 Sierra Leonean children don't live to their 5th birthday. And the normal sort of rates of 10% of girls will finish school. In 2013, Transparency International said that Sierra Leone had the highest rate of bribery in the world for public services. And so when I think back to when we started hearing about the cases in Guinea, I remember just thinking, God, we're so overwhelmed with everything else. Maybe, after the Civil War and all these sorts of things, Sierra Leone might just once, dodge a bullet. And just to sort of give you a bit of a visual indication of that, 70% of the population of Freetown, where Oliver and I were living, live in slums. And this is one illustration of that. So when you start thinking about, a health crisis that has a lot to do with hygiene and sanitation and so on, it's just bearing in mind that the starting point of people can be so incredibly challenged. So basically what happened in 2014 was that in this red circle, let's see if I can use this clicker. Oh, there it is, look, I've never used one of these before. This red circle here, and actually quite close to Kisadugu and a quite large city of Gwekadu, is where you had the first ever case of Ebola in West Africa. It was an 18-month-old baby called Emile Mwamwano. Most likely now in retrospect, we think probably playing under a tree near his house, where there used to be bats that would be at the top of the tree. Probably he had some kind of interaction with the feces of those bats. And that led to the first Ebola case in West Africa. But of course, because West Africa hadn't seen Ebola and it had mostly been in Congo and to a certain extent in Uganda, it took 3 months for the world to realize that this was actually this disease called Ebola. So it was only most likely Emile's infection took place just over the Christmas period in 2013, and it was the 21st of March by the time it was identified, after the disease had this mysterious disease had killed all sorts of people, family members and others in the local area where Emile lived, and then health workers, and then other clinics and so on and so forth. This, I think, one thing to also bear in mind, talking about context, is that it's very significant where exactly this happened, because as you can see, it's in Guinea, but it's very close to the border with Sierra Leone and very close to the border with Liberia, these original cases. And geography is important here for a few reasons, partly because these borders are, of course, relatively recent creations, and a lot of the people living in this area were from the Kissi ethnic group and going back and forth across the borders, as they always have done. But a group that often, particularly in Sierra Leone and Liberia, were very marginalized from the centers of power. I mean, physically, it's quite remote from capital cities, but also politically tended to be more sort of, seen as not really central and not getting good public services. And these sorts of issues became very significant during the Ebola crisis, but we'll talk about that later on. So I think Oliver will continue.
Yeah, so I'm going to pick up the story a bit. So I was based, as has been said, at the main government hospital, Connaught Hospital. So I was a medical graduate from London, but I hadn't done my foundation training. I'd focused instead on academic global health, on health policy, and I was working embedded in the main teaching hospital, Connaught Hospital. Little office next to the medical superintendent, working with the medical school, the hospital, the Ministry of Health on long-term health systems work, and had a team of about 3 or 4 volunteers, mostly from the UK. By good fortune, a Spanish infectious disease consultant had just joined our team when the Ebola outbreak started. And pretty quickly, after those first cases were diagnosed in Guinea, the Minister of Health in Sierra Leone had set up a task force So the UN agencies, the international NGOs, people from the Ministry of Health in Sierra Leone got together to start preparedness planning for possible cases that would come in. But even at that stage, the response really went in the wrong direction. It was very much a paper exercise. So King's, for example, was asked to contribute to the clinical planning of how do you get hospitals prepared for an Ebola patient that might come in through the front doors. And I think one of the things that surprised me is in those early meetings, we thought the World Health Organization would be taking the lead of those discussions, and they weren't in the meetings because in particular in Sierra Leone, they had virtually no clinical presence. Their work was very much public health policy, but they really had no clinicians to contribute to a discussion on medical care, and they weren't present. And so it was actually very small NGOs like King's that played the most active role in supporting the government. And so we downloaded the WHO guidelines and worked with the Director of Hospitals to adapt them for Sierra Leone, and then it came out to distributing them, and we asked for a list of the government hospitals in Sierra Leone, and the Director of Hospitals didn't have one. So even the presence of working out what are the hospitals in Sierra Leone, what are the contact details, trying to email these guidelines out, but most of the hospitals didn't have internet access. If they did, very rarely were their printers working. So the physical challenge of simply getting these guidelines into the hands of the medical superintendents of the government hospitals took us weeks and weeks. We had to call up NGOs saying, could you just print them in your office and drop them off there? There was no response, there was no funding for any of this. We were doing it on top of our day jobs. And so people were saying the hospitals were prepared, but in practice they were lucky if they had received the guidelines, let alone any meaningful supplies or funding or support. Similarly on training, one junior doctor normally, and one nurse from each hospital, I think had a 2-day training in Kenema, which was almost all by PowerPoint. And they were sent back to their hospitals and told to do a training of the trainers, to cascade the training out. And it was a ridiculous idea that was ever going to work. Of course, that was an impossible thing to do after a PowerPoint training. But yet the box was ticked that people had been trained. And so people were saying how well prepared Sierra Leone was, but of course that preparedness was meaningless. And so when Ebola was then first diagnosed in Sierra Leone in May, so 2 months after the Guinea outbreak, it spread very rapidly, particularly within health facilities. A lot of health workers were infected. And here is the small isolation unit at Connaught Hospital that King's supported the hospital to set up. It was originally a 2-bed isolation unit. We found a couple of old cholera beds. They still had the DFID logo on from the cholera outbreak a couple of years before. And we thought, at worst, we would see a handful of patients in Freetown because there was this sort of established wisdom that Ebola did not cause big urban outbreaks. And no one could tell you why, they just said it was the case. And of course, that turned out to be completely wrong and contributed to our underpreparedness. And so pretty quickly, we had one patient isolated in this room, then a second. And then I remember in the afternoon, and this was in about June 2014, a phone call from the emergency department. A third patient had been identified in the emergency department, nowhere for them to be isolated. So that night, we worked to set up a large isolation unit. The medical superintendent shut down half of the emergency department, and we worked through the night, very basic stuff. So it was plastic sheeting, fans, buckets, chlorine. We built this in about 3 or 4 hours. You can see the maintenance staff taking the lead there. And by about 11 o'clock at night, we had it ready. And we thought, okay, well, at worst, if it gets really bad, we might see a dozen patients. But actually in this room, we saw more than 1,000 patients, of which more than 750 tested Ebola positive. So the scale of what was coming was simply a different order of magnitude than what we'd seen before. This is twice as many Ebola patients, roughly, as the largest ever previous Ebola outbreak in this one room and the adjacent room. Pretty quickly, this isolation unit was full. Patients were coming and collapsing in the hallways of the hospital. We couldn't grow any larger. Most of the staff were on strike because they hadn't received the right protective gear, on strike because they hadn't received the hazard pay they had been promised. And so it was an incredibly difficult scenario, and we had patients just collapsed on the hot tarmac outside the hospital for week after week. And the reality was that there was very little still in the way of a response. So this is a photo. One of the things I found, I went up to the Sierra Leone military hospital. They'd built a really nice, small, 10-bedded Ebola unit, but I found it was half empty, even as we had patients collapsed outside of our hospital because there was simply no coordination in place around where are their patients, where are their beds, where are their ambulances. So we worked with the district health management team to set up this room, which was the Freetown Command Centre. It later became a huge auditorium, about 5-10 times the size of this room, with soldiers and trestle tables, and everyone from the Archbishop of Canterbury came to visit it, but it started off in this small room here. And you can see it was a flip chart paper, and it was whiteboards. The small whiteboard at the bottom, you can't quite see it, that was a list of patients who had been identified by disease surveillance officers as probably having Ebola, but there were no beds to isolate them in, and so they were quarantined in their homes with relatives. And for week after week, that list just grew longer and longer and longer because we didn't have the capacity. Now, this is the 29th of September 2014, so this is 4 months after the start of the Sierra Leone outbreak, 6 months into the regional outbreak, and you can see this was Freetown City. By this point, this was the epicenter of the regional outbreak of all 3 countries. Connaught, Macaulay Street, and Newton, those 3 isolation units were run by King's, a British university, 34 military by the Sierra Leone Armed Forces, and LACA by a small Italian NGO, and that was the entire clinical response in the capital city. And every single day, how many beds were available? 0, 0, 0. How many treatment centres were there? The beds were full. And that was just a reality day after day after day. And you know, we were really waiting, and panic began to set in across the country. The fear on the streets was palpable. The airlines, British Airways in particular, cancelled their flights. It led to a cascade of flight cancellations. A lot of international partners began to evacuate. We started to feel very isolated in Freetown, really alone. We heard about the outbreak in Nigeria, and we could only imagine how far we now know it didn't spread across the continent. We didn't know then it wasn't going to spread much more widely across Nigeria and the continent. And so it was really, an unprecedented, uncertain moment. And at this time, the CDC produced this model that said if the response didn't improve, you could see 1.4 million infections in Sierra Leone and Liberia in the next 6 months. And that would have been 1 in 10 people in the population. And I remember driving back from the hospital very late one night and just imagining, as I sort of drove through the crowds on the streets of Freetown, 1 in 10 people being infected. Not only what a humanitarian crisis that would be, but what would it mean for the government if 1 in 10 people were sick? Would police officers, would the army, would they just stop going to work? Would the state continue to function in any capacity if the outbreak got that bad? And we just didn't know where it was heading. So I'll hand back over to Sinead.
Yeah, so it was a very surreal time to be in Freetown, and I mean, I guess my main role was in sort of what could sort of politely be called advocacy, and maybe less politely has been termed as harassment, which I can accept because we couldn't really understand. I mean, the world just seemed to be asleep. You know, as Oliver is describing, you know, to us this was Armageddon. You know, we had absolutely no idea. It was already the worst Ebola outbreak ever. We had no idea how bad it would get because it was exponential and so on. And it really just seemed like, you know, nobody was paying attention. And so my role was sort of, you know, going around the country, talking to people like Oliver, Sierra Leonean district health staff in different parts of the country, and trying to feed back what they were saying and what their needs were to, you know, to the sort of the national level. That we had not a very effective presidential task force at the time that was supposed to be working on this, would have sort of 5-hour meetings and not really achieve all that much. And also, of course, you know, trying to get WHO in Geneva, the UN in New York, and others to really you know, provide some resources. So, I mean, one example, this guy over here is actually, he was our minister, the Irish Minister for International Development at the time, and when he came in the beginning of October, so bear in mind, you know, this was, you know, 4 months after the outbreak had started, 4.5 months after the outbreak had started in Sierra Leone. He was the first politician from any country to voluntarily come to Sierra Leone during the crisis. And even though it was starting to be in the media back in the Western world, we still didn't have, there was a huge amount of fear, and a lot of people were sort of saying, yes, we can see this is bad, but of course, you know, we're staying very far away from it. So one of the things we did on his visit, apart from visiting the command center and those whiteboards that Oliver was just showing you, was sit with the president and try and convince the president that the salary payments for health workers needed to be not done by the Ministry of Health, because they were being siphoned and the health staff were just not receiving their salaries. And ultimately, well, the President did actually agree in that meeting that we had, and ultimately a separate national Ebola response centre was set up. But I think, you know, what really was sort of our overriding feeling in those early months was a real puzzlement as to where the sort of cavalry was that's supposed to kind of, you know, swoop in, as we thought, in a crisis like this, and who know what to do. Because those of us who were there working on this, we had no idea what to do. We didn't understand this disease, and we just assumed that there were people who would kind of swoop in, and we couldn't understand where they were and why they wouldn't arrive. Now, what ended up happening was we did get a sort of a huge international response, and the lady in the middle here, Samantha Power, was one of the global driving forces behind this, along with Barack Obama. They literally, and she told us this when she visited, they literally sort of sat down in early September and went through a list of world leaders and just called every single one and said, okay, South Korea, can you provide some PPE? Can you provide some ambulances and so on? And eventually, I mean, it kind of started in September. The verbal commitments were made in September. And from October, but more really in November and December, we did really start to see a lot of international resources coming into Sierra Leone. You know, ultimately we had hundreds of ambulances. We had, you know, hundreds of treatment beds. We had the protective equipment. We had all of this. But in a way, I think Oliver and I, speaking about this later, we sort of were quite surprised actually that in a way the cavalry that we had thought about actually never arrived. Because when all those resources came, what we saw was that they didn't work right away. You know, the resources came and all the people came, and I think there were 1,000, you know, British government, because one of the agreements that was made in September was that the UK would take a leadership role in Sierra Leone, the US in Liberia, and the French in Guinea. The latter didn't really happen to the same extent, but the US and the UK did take a very strong leadership role. So we had this sort of huge UK military presence, but even when all those individuals and all that money started to come, it took a really long time for that to start actually having an impact on the ground. And really that was because, of course, this was a very complicated local context, as are all local contexts. And so it took a long time and quite a bit of assistance from some of us who'd maybe been in the country for some years for that international response to actually lead to, you know, more people showing up at the treatment centers and the various issues that we were facing. And there was a lot of politics in the response, and a lot of that had to be worked through. So it was really, really quite slow, and it was a real grind. And it actually took, from that first case in May of 2014, it took 21 and a half months for us to get to zero in Ebola in Sierra Leone. And, you know, whenever I say that to people at home, they're always like, oh, that doesn't make any sense, because, you know, I was following the media, and it was in the media for a couple of months, and then it was gone. So I thought, you know, it's over. And I was like, no. But it became considerably less sort of, you know, sexy and dramatic, but it did definitely take a long time and a long sort of hard grind to get to zero. And when we eventually got to zero, there were a lot of celebrations and, you know, a lot of, you know, kind of, you know, people in the response and, you know, congratulating each other and themselves, and, you know, the sort of, you know, we got there in the end, and this kind of approach, and there were medals from your queen, etc., some of your queen maybe. And I think for Oliver and I, it was actually quite uneasy. And for a lot of us who had been there from before it started, I'd been there in the country 3 years before the epidemic had broken out. And I think we just were very uneasy with this mood of self-congratulations, because we were so haunted by what we hadn't done, all the mistakes that we had made, ourselves included, the huge delay in doing anything about it, and therefore 3,956 Sierra Leoneans who had died of Ebola at the very, very, very least, because we know, particularly that red circle that I showed you, we know that a lot of people died in the early days, and they're names were never written down on any pieces of paper. We also know now that more than that number died because of Ebola from other diseases. So you were on HIV treatment, forget about that. You were on a long-term TB treatment, that's interrupted. You tried to give birth during Ebola in a country with one of the highest maternal mortality rates at the best of times. And there's no health staff in the clinic because the health system collapsed. So Ebola, had such a huge set of secondary impacts that we didn't pay enough attention to. Its impact on agriculture, its impact on the economy, all these kinds of things. So we really struggled, and it was actually during that period that, again, accidentally, Oliver and I ran into each other and ended up having this conversation, sort of / vent, about how we felt as though the story of the response was being rewritten kind of by the victors in a way, and that there was really an honest story that needed to be told very directly about what had actually happened, because otherwise, how would you ever not just have this happen in exactly the same way again if you sort of just let yourself forget about all the mistakes that we made. But on the other side of it, we were also very aware of so many heroes of this response, particularly Sierra Leoneans, particularly Sierra Leonean health workers, many of whom died. And we were really keen to tell some of those stories and talk about some of the commitments and sacrifices, because it was incredibly hard work and took, as I say, a very long time and a huge amount of commitment and new thinking and new partnerships and innovation to get to zero. So we wanted to recognize that as well, and so all of that sort of led into the book, which is also, since I'm in an academic environment, informed by 85 interviews and a sort of a very, very large document review, partly to challenge our own perspectives, because the book is entirely written in first-person narrative, either mine or Oliver's. But we were also conscious that, you've such tunnel vision when you're working on a crisis like this. And sometimes you got very angry with someone, be it a minister for health or a head of WHO or something like that, but you didn't necessarily have any idea what their perspective was or what challenges they were facing. And so we interviewed all those people who made us angry, and sometimes it didn't make us any less angry with them, but sometimes it did sort of, okay, that's fair, okay, I hadn't, So just also to challenge our own sort of biases and blind spots during the response. But mostly it's a book about stories. And maybe just to finish up, we have 5 big lessons we just run through quickly. And the first one, I think for people at IDS is a bit of a no-brainer, but still something which was 100% the biggest failing of the Ebola response, which was the area of community engagement. And I mean, even the picture itself, if you're an anthropologist or a social scientist, you'll probably cringe already with the poster, with the checklist and the loudspeaker and so on. And this was the fundamental problem, was that we were giving instructions, biomedical, correct, rational, logical, from our point of view, instructions, and we were baffled as to why, we weren't really making progress. We were using a very punitive approach. This was something that the government, felt very strongly about. So we had a quarantine policy, which was unfortunately not, how should I say this? Not opposed by the British government, unfortunately, opposed by some of us, quite unsuccessfully for the entire response. We never managed to get it changed. But we basically had a policy that if you got Ebola, you were taken, if you were lucky, towards, later in the response when there were treatment beds, you were taken away. Your entire household was locked up for 21 days in case they started showing Ebola symptoms. So just imagine how people in that household feel. So you're usually, you could be talking about 12 people, 16 people, 24 people, the household sort of broadly defined. And your loved one has been taken away from, this mysterious disease, and then you're locked up. You can't go to work. you will lose your job or you will lose your harvest. I mean, your average, very high unemployment rates in Sierra Leone. A lot of people are sort of on the edge of poverty, if not in poverty every day. But you're also being locked up with people who might have Ebola, making you more likely to get Ebola because you're locked up with them, even if you were not particularly at high risk from your original interaction with your loved one. So it really did not make anybody feel like the government cared for them. And thinking back also to the red circle on the map, a lot of the people originally affected by Ebola already had a great deal of distrust of the government. So clearly, and sometimes also of foreigners for a lot of good historical reasons. So clearly that none of this was going to help, but this was the approach in Sierra Leone. It tended to be very punitive. And so what happened, unsurprisingly, people tried to escape. They fled, they went into the bush. If you heard that somebody was taken to a treatment center, you would not go home. And so then, of course, it's completely counterproductive, and you have people, some of whom have Ebola, just doing everything they can to stay away from the response. And so, but unfortunately, we were never able to change this policy, although towards the end of the response, we definitely came up with much better community engagement practices, and I think the anthropology platform had a role in that. We started, working in a more empathetic way. One of the things that was a key issue was around, as I mentioned earlier, these secondary impacts. This was an MSF nurse who said, if somebody shows up with a child with diarrhea, if it's not Ebola, they'll be sent home. We don't care about you if you don't have Ebola. If you have malaria or diarrhea, that's, there's no care for you here, that kind of empathy. We did get better, particularly with some strong Sierra Leonean leadership in the response in the later months, at recognizing some of these things, at starting more with where people actually were, rather than telling them what we thought they should do, actually starting to say to people at community level, well, how do you think you can defeat this virus, and how can we support you to do that? But as I say, that realization took too long, and that had great costs. But we do try in the book to talk about some of the good examples that came out at the end, again in the hope, and we're sort of back and forth with some people working in the Congo, and they are huge challenges, which we can maybe talk about later, in what's happening in the DRC at the moment. But they have tried to use some of the good practices from West Africa. So that's the sort of first, and I think for us, the overwhelming lesson of the book about community engagement. The second then is about leadership and coordination. This is Barack Obama hugging Nina Pham, the nurse in Dallas who recovered from Ebola, and President Koroma with some local chiefs, the then president of Sierra Leone. And so leadership in the response, in the beginning, really weak. WHO, there's no secret, they've been completely excoriated, and they've excoriated themselves for their role in the early days. And to be fair, they did improve over the course of their response. But I will also say that the UK government intervention on the leadership that they took at the national level on Ebola in Sierra Leone was absolutely critical and absolutely turned things around. And I think it's important to recognize that, much as our book also gives them a hard time for various things that we wish they had done differently. So leadership and coordination in the beginning, really chaotic, really weak, but did eventually, come through, and the government also improved a lot. President Koroma did really kind of take this on in the end, and we did see changes. The Sierra Leone Army also, maybe slightly surprisingly, they were the national institution that by far stood up and were extremely effective on Ebola. The medical corps of the army were one of the ministry didn't do so well, but the medical corps of the army were very important. And the third lesson then is around politics and accountability. And I think this comes as a surprise to some people because often Ebola is seen as this sort of a technical thing, and it must be so medically complex and so on. Actually, for all of us, including the health professionals like Oliver, by far the biggest challenges we all faced every day on this response were politics and corruption, power, these sorts of issues. not technical issues, not knowledge issues. And this is something that we found really important to bring out in the book, because we find that it's often not spoken about, and that maybe there's a kind of a political correctness about, speaking about these issues. But again, how do you learn if you don't really honestly speak about what dominated your day-to-day lives, which was for us very much these kinds of issues.
And just picking up from there, I mean, that was actually one of the points where Sinead and I interacted. We didn't work closely together in the response, but just on the front line from the clinical side, that issue of politics was absolutely every day what was obstructing the response. For example, you saw that small Ebola unit at Connaught. When we had a little bit more resources and volunteers, we worked to support other local hospitals to set up their own Ebola units. And often the medical superintendent of a hospital in Freetown would come and say, could King support us? And we say, we're happy to, we've got funding from DFID. But the ministry, someone in the ministry would block it. We didn't always know who. We could not get permission. Why was that? It was because sometimes an international agency had their own politics. They wanted to take the credit for something. Sometimes there was local politics. We hadn't paid the right person, or there weren't the right interests involved. And so that was what, in particularly September, October, what I was pulling my hair about, and I'd go to Sinead and say, I don't know what to do. Like, I've got these people dying outside, and we have the capacity now to do something, but I can't get it approved. So I'd speak to Sinead or the British ambassador or others in the Sierra Leone government, but that was the reality. Another big issue was this issue of working through government systems. Now, this photo on the left is of Freetown, which you may remember was the so-called crown jewel of the British response. It was built by the British Army, the Royal Engineers. It was operated by the Ministry of Defence and Save the Children. And from the first moment the British agreed to run it, which I have recorded as 12th of August, it wasn't until the 5th of November that it was able to admit its first patient. And even then, it opened very slowly. I think it saw 4 patients in its first couple of weeks. This was at a time not only when we had patients dying on the tarmac outside, but also when the Ebola outbreak was getting exponentially worse. It was a race against time, because it's getting worse and worse every day. And so these delays made it harder and harder to get the outbreak under control. And why did it take so long? Politics and leadership was part of that. But, the idea of having to clear the bush, literally, you can see it carved out of the bush, putting in roads, putting in concrete floors, putting in electricity, security, creating a new hospital staff, a new hospital supply chain from scratch is an incredibly difficult thing to do in the best of circumstances. It's harder when you're dealing with a risky disease like Ebola. By comparison, what we at King's were doing is we were partnering with local hospitals and helping them to set up much smaller Ebola units that they could run, and we were just providing them with some logistical, technical supports and supervision. So this is an example, Macaulay Street, which is a small government hospital in the centre of Freetown. The first conversation we had about opening this unit was on the 24th of October. On a Sunday, the medical superintendent called me up, and we were able to have patients admitted to this new unit by the 31st of October. So we were able to move much, much more quickly by partnering with the hospitals in Freetown. It came with political challenges. I've mentioned them already. It wasn't easy, but it could be done. It could be done safely. And to put it in perspective, that unit cost about, I can't quite remember, probably $3,000-4,000 to build. By comparison, the unit at the top there cost £80 million to build and operate. So, they're not quite the same thing. This unit's bigger, and it had a very great standard of care when it ultimately did open. But you can see in terms of speed and cost, it was just a completely different order of magnitude. Now, it's not always possible, and Sinead often points out that in situations where, for example, there's active conflict and the government is a party to the conflict, it's not always possible for international partners to go directly and collaborate with the local government hospital. They'll be seen as part of the conflict. But that was not the case here. And yet the sort of immediate response of a lot of international partners was to go it alone and develop their own systems. But more broadly, there's a bigger point here, which is that in terms of the health system, what we saw when Ebola was introduced to Sierra Leone is the health system collapsed like a house of cards. Because in local clinics, which one of the directors of ministry had just before Ebola described as an empty promise in physical form, because so many of these clinics had been built but had never been opened, had never been staffed. Staff hadn't been paid for months sometimes. They hadn't ever been well trained. There was no supply chain of gloves or soap. The borehole had long since broken. There was no running water. And so very, very quickly the health system collapsed. And yet, since the war, we had been saying that we were doing this great job of health system strengthening. And clearly, whatever we had been doing on health system strengthening before the war had not been working. And at the time, a lot of people from DFID and the WHO and the government of Sierra Leone were hand-wringing and saying, you know, we're going to build back better, we're going to make a generational investment in health after this, we've clearly what we were doing wasn't working, and yet afterwards we went straight back pretty much to business as usual, some marginal changes, but really not the fundamental difference in approach to health system strengthening. And so, you know, I was in the DRC, not where the current Ebola outbreak is, I was in the far west in August. The main regional hospital for a region that's the same size in population as Sierra Leone, on the wards, none of the wards had sinks, none of the wards had running water, you know, so the same stories are true. And of course, this issue that Sinead mentioned, that general health services were not maintained during the outbreak. So a lot of lessons around working with government systems. Our final point is the importance of individuals. This on the left is Yvonne Akisoya. And Yvonne was a businesswoman working in London, a part of the Sierra Leone diaspora in London, at the start of the outbreak. And when the outbreak started, she was determined to contribute to the response. She got on a plane to Sierra Leone, went to the National Ebola Response Centre and said, you know, how can I contribute? She was made National Director of Planning for the response, and she was one of the people that Sinead mentioned, played a really important role in strengthening the Sierra Leonean leadership of the response and bringing empathy to that response, much better engagement with the communities as a result of her work. And there were many others, like many young doctors in the Sierra Leone Armed Forces, but also within the WHO and other organisations, there are individuals whose role really made a substantial difference to how the outbreak played out. And in the book, we talk a bit about those individuals and what it was about their approach that made them so effective in that situation. And we're really pleased that Yvonne, earlier last year, was elected Mayor of Freetown, as you can see on the right. So she's now leading some fantastic changes in the city around improving those urban slums that you saw photos of, improving sanitation, improving governance in the city and so on. And so we're kind of optimistic that maybe there will be some changes as a result of that. And in the book, we try and talk about them. And we're really pleased that she was a fan of the book. We're off to Sierra Leone in a few weeks because we also want to have these conversations with students and health professionals and government colleagues in Sierra Leone. So we'll be going to Freetown and hopefully some of the other cities to try and kind of continue this conversation there. But on that note, I think we both want to say thank you very, very much for your attention and open this up to a discussion. Thank you.
Well, thank you both so much. That was completely fascinating, and I'm certainly going to go off and read the book now in detail, and you'll have an opportunity to buy it at a very cheap price afterwards if you would also like to. But we've got some time now for any questions, discussion, points you'd like to raise. I know there are people in the room who were also engaged with the Ebola response in one way or another, even if not on the front line, but a little bit more distantly. So let's open it up. Questions, comments, we'll maybe take a group of them at a time and then come back for some more. So who'd like to start? Yeah.
Hello. My name is Erica. I work here as researcher with the participation cluster. So no surprise, my question goes to the community engagement, empathy, different ways of working, type of how. Or do you have any plans to work with the training institutes of the, very low level, let's say local level community health workers? Because I think you've realized that at the end that was a very strong force to work with. And wondering about maybe, are you translating some of these lessons to local languages so people can also access them when they don't speak French or English or any other?
Hi, my name's Steve. I enjoyed the presentation very much. I work on taxation, and we also have some good work in Freetown. Mm-hmm. So I hope the mayor is supporting that. So a question for Oliver. You were under incredible stress. How did you feel when the health workers went on strike?
It seemed like some of the lessons at the end, coming through are about lessons about kind of maybe an epidemic and emergency response. But what really struck me in your presentations was the legacy of these empty promises, and that's development and how development was being done. So given that you were both there originally working on development and health system strengthening, and thinking again about kind of all the attention going towards preparedness at the moment, what are the lessons for health system strengthening and preparedness and development as opposed to emergency response?
Okay, well that's three rather different areas to begin with. I mean, decide between you how you want to take those.
Shall I sort of start with some comments and then Shade, you jump in? I think on that the first question around participation and so on, I mean, one thing I want, as Shade said, we are quite critical of others in the book, but we're also critical of our own mistakes. And there are certain things that I really regret, and one of them is that, you know, I come from a global health background, so when I was teaching global health, I talked about the importance of anthropology and the center of global health and all these things, and yet when I was on the ground in the hospital, I was pretty obsessed with nurses and beds and PPE. And I guess as the structure of the Ebola response was set up, there was a social mobilization pillar over there. I was in the case management pillar, and I said, that's really important work that they're doing, I'll leave it to them, without realizing that it's everybody's business to do community engagement, and that my role in the hospital, this is a flagship hospital, the government of this country, it is on the front page of the newspapers every day. The Ebola unit I ended up managing, and incidentally we didn't want to manage it, we wanted to support colleagues, but the Sierra Leone doctor in charge tragically got sick and died, and at that point we were asked to step in and run it. I didn't think about how the burial vehicles coming to the front of the hospital 3 times a day, the hazmat suits, the white tarpaulin, everything else was going to contribute to the fears and concerns and anxieties, and it wasn't part of our kind of thinking of the hospital, and I think we therefore made the problem worse by not thinking about it enough. And at the time I said, I'd love to do it, I don't have time. And it's true, like, I mean, I really didn't have, on one level, I really didn't have time, but more importantly, I didn't have time not to. And I think someone earlier in the week pointed out that it's a real leadership kind of challenge to be able to say, yes, there's bodies outside, but we're going to have to put that on hold, because it's more important that we spend some time talking about community engagement and anthropology now, which is a difficult thing to do when you face a very tangible, hard problem, hard in terms of kind of solid problem. I would just add to that there's some quite good work now going on at the hospital, at least at Connaught, to try and get patient feedback, patient feedback has just not been part of the kind of concept of the hospital really in the past, but now there's a big shift towards that and a much more engagement on it. I don't know about what's going on so I know it's becoming more part of the kind of formal structure. I know less about the local training institutes, although I agree it's a really important part. I think we probably were slow to use the expertise of community health workers, also international NGOs who were there, because I think there was a bit of a brain freeze early on around Ebola. Everyone said Ebola is so different from anything we've ever faced before. We don't know what to do about it. And we didn't always use the tried and tested things we know about from humanitarian responses, because I think people were a bit blindsided by Ebola, and I think that was a mistake. And I think the point about local languages is really important. I mean, I think we were both conscious when we were writing a book that the majority of the population of Sierra Leone not only is not English speaking, they're not literate. So a book is not a great format always for that group, and I think it's an interesting question we should think more about. Just in terms of other questions, but I think, do you want to answer more on that?
Yeah, just on the first question. I mean, I think we're very open to others also, kind of working on trying to disseminate some of these lessons. The book isn't even in French, by the way. I mean, but I mean, I think that there's a lot of potential. I mean, we're sort of donating all of our proceeds to Sierra Leone, and our publisher is a cooperative. So, I think we're all sort of nobody's really trying to make money out of this, which is just as well. And I think we're just very open. We've done a lot when the book first came out. We did a ton of media, and we sort of did 14 talks in the US. This is our 12th talk in the UK. We're going to Sierra Leone. I'm doing talks in South Sudan. He's doing talks in South Africa, but we're also just really open to if anybody else wants to talk about the book. And we're thrilled. There's some book clubs that are talking about it. We try to talk to a combination of practitioners and students, And, you know, I guess we're just really open to if anybody, you know, wants to propose, you know, translating, you know, summaries or this kind of thing. We're really, really open to it. We don't have any kind of particular plans on that at the moment, but, you know, I think we're keen to sort of get it on syllabi so that it has a bit more continuity within kind of academic settings. But yeah, we're pretty open-minded, and I know our publisher's also pretty open-minded as to how we can kind of work more on dissemination.
And you know, you made me think we've done quite a lot of media in the US and the UK, but we haven't really talked about Sierra Leonean media, which might be interesting.
It'd be interesting. We go to Sierra Leone if there's interest in that. I mean, you know, again, coming back to politics, we've also been very aware that this happened in a very particular political context in Sierra Leone. So we can also be used as a political tool, but we will cross that bridge when we come to it.
The second question on the strikes, that was an on-point question because it was immensely challenging when, you know, we would arrive at the hospital and sometimes there was only 2 people on my international team. We would have 25 patients sometimes in our unit who were desperately sick, and about half of those would die every day. So just the scale of dealing with that was really difficult. And then for week after week after week, you know, a lot of our staff would be on strike, and there would be, you know, I would have to spend hours trying to negotiate with the ministry to get people paid, and I was dealing with the intransigence of that, and I felt very conflicted. But at the end of the day, you know, most of the reason why people volunteered to work in our Ebola unit, a significant reason was that they weren't receiving any government salary, and this was a big problem. In our emergency department, pre-Ebola, almost all of the nurses who had been there for years were not on any form of salary. They only existed off payments from patients because it took years to get onto payroll. So it's hard, you know, not to empathise with them after going month after month. In particular, so many of the health workers who worked in our Ebola unit, they were kicked out of their homes by their landlord or by their families because there was such fear that they would bring Ebola home. And so, you know, in Kenema, there was nurses would come back from a shift and they would find their family had packed up their bags and the bags were on the street outside. It was a really challenging scenario, but you can understand why when so many families were getting sick. On top of that, so many Sierra Leonean health workers were getting infected. Almost all of those were dying because, unlike me, they weren't going to get medevaced. You know, they weren't going to get a good quality of care. I think there were about 12 Sierra Leonean doctors who got infected with Ebola and 11 died, so it was perceived as a certain death. One of our consultants at the hospital talked about driving to work and hearing his own death announced on the radio. So you can just imagine how he and his family would then feel about that kind of pressure. And of course, no life insurance. So, you know, if you're a health worker, if you're a doctor or any health worker, you're probably the main breadwinner for your entire extended family. If you die, not only do you die, which is, you know, for most of us, I think we would consider ourselves dying as about the worst thing that could happen, but actually if your entire extended family is then left in poverty because they can't be paid. So it was incredibly challenging because patients, I can't tell you, and we document it quite a lot in the book, the lack of dignity for those patients. The quality of care in the unit that I ran was appalling. Towards the end of the Ebola outbreak, Paul Farmer from Harvard came to Sierra Leone and he held this event at the Radisson, and this young Sierra Leonean guy walked past me and it was like I'd seen a ghost. And it kind of filled me with kind of dread, and I didn't know where I'd seen this guy before. And eventually I worked out that he was actually one of our first patients at one of our units when that unit was in particularly poorly, for political reasons, had really poor conditions. And I hadn't known he'd survived. I just assumed he'd died because so many of our patients died. And to see him alive, and all I could do was apologize to him. I was so apologetic for the appalling care. You know, you go to bed and overnight all of the patients in the room with you die and their bodies are left to mourning. Can you imagine being in a room alone with 5 dead bodies when you yourself are sick every day? The lack of dignity was appalling. The last point on health system strengthening. I think one of the fundamental problems, I think, is there's so much scrutiny of aid money. There's so much question around value for money and demonstrating impact. And in health, that means shifting the focus and the lens right towards the very last piece of medical care, which is the interaction with the patient. And on one hand, you know, it's important that our aid money is well spent and it has impact. But the result of that is all of these programs kind of start with the child who needs a vaccine, and then you go in and you inevitably find, okay, well, actually none of the staff have been well trained at their nursing school, none of them have been paid, you know, there's no supply chain, and then you try and retro-engineer a health system starting with a kid who needs a vaccine. And working backwards just doesn't work, and that's why you end up with all these, you know, incentive structures and parallel systems and everything else. And I get why, because DFID, you know, DFID's, I think, the only government department that is audited 3 times. The scrutiny that DFID gets versus, say, the MOD, who could spend on warships, so, you know, and we don't really pay that much attention to it, but the Daily Mail puts this on the front page every day. So I think part of our problem is, I was speaking to a journalist yesterday, I think, actually, and I was trying to get her to do a piece on health system strengthening. She says, it's not news, I can't make this news. And that's part of the problem. So I think because of that, we are kind of doing a lot of kind of retroactive design, and what we need to find a way to do is make the case for a generational investment in medical and nursing schools, community health worker institutes, in good salary payments, in the really long, hard slog of trying to get procurement trains to work without too much leakage. But we need to recognize that we have to find a way of selling that to the public in a way that is kind of convincing and not just looking for a technical solution, because that alone isn't going to survive the political environment of aid. My PhD is on how to support early career doctors in Malawi and Zambia to strengthen their leadership skills. So I think part of this is to say we need to be more responsive to what colleagues on the front line of those health systems want to change and kind of back them in that process, rather than doing, you know, saying I've got a 40-country program and I'm just going to do a cookie cutter model of delivering the same thing in every context. And even if no one there locally thinks it's important, I'm going to use my incentives and my pressure to kind of ram it through, because we know that doesn't work. But I think in particular one of the challenges is the unpredictability of funding, because, for example, the project, I only had 1 grant when I went out to Sierra Leone. It was a £118,000 grant over 3 years to help the medical nursing pharmacy school to develop a new curriculum. Now, King's College London has just developed a new medical curriculum, and I think it's a 6 to 8 year process at King's to do that. I had 2.5 years to do it in a university where some departments had no staff. So the time allocated to projects versus actually how things work in the real world is completely misallocated. And I think one of the things I'm really interested to do as a consequence of this is have some more discussions around how supporting countries in health system strengthening, especially when universal health coverage is such a flagship project for the WHO, how do we need to shift our approach to be one that is going to work more effectively? And I'm sure people in this room have a lot of ideas on that.
And Sinead, fantastic. Sinead, do you want to comment at all on the health system?
Just really briefly.
Beyond
Yeah.
health system strengthening, one of the things
Yeah.
we did during the outbreak was to produce a series of briefings on Ebola lessons for development.
Yeah.
It basically said this was a crisis of poor development, which is partly
Yeah.
health systems, but it's also conflict, lack of trust,
Education.
Governance.
gender,
Governance.
poorly
Governance.
targeted
Yeah.
foreign direct investment that had led to all kinds of livelihood problems and
No,
mistrust.
and I read all those
Yeah.
briefings, and I agree. I mean,
how does one build back better, to use that phrase?
Yeah.
Or what are you doing now in South Sudan as they see a Ebola outbreak coming across the border?
yeah, I have to say, it's going to sound like a strange thing to say, but it's actually really nice to get to work on Ebola preparedness in South Sudan, because I know some stuff now, and I did not know anything when we were working on Ebola preparedness in Sierra Leone. So it's actually really, I mean, you know, fingers crossed we'll never have to use this preparedness, but it is actually really kind of psychologically nice to be able to directly use some of these learnings. I mean, I would just say, I mean, on the question, I actually think pretty much all of our lessons are sort of just as applicable in a development context, maybe with slightly different slants. As you pointed out, I mean, we're both development people. I mean, I believe I'm a development person. I do keep ending up in humanitarian crises, but that is not my choice. It's not my decision. But you know, I think as we were writing the book, I think we both felt as though, you know, issues around, you know, sort of the community engagement, which then implies, you know, a really deep engagement with a country's, you know, history and you know, relationships and so on. I mean, you know, that's absolutely critical for any kind of development program. And, you know, sadly, you know, the timelines of our projects, the turnover of our staff, I mean, these things are all working against that, you know. But I think the lessons are more or less as applicable, and we actually, it's one of the reasons why we try to speak to also a lot of development studies, you know, classes and stuff, and not just the humanitarian and the global health people, because actually we really do believe that. So hopefully it's useful, you know, to a development audience as well.
Okay, so let's take some. Yeah, we've got time still. So yes.
Thank you. My question pertains to the governance and the politics of it all. Has there been any follow-up that you're aware of in terms of Irish Aid or the European Union or the British in terms of the health systems that are currently either in Liberia, Sierra Leone, and what does that look like, if you can speak about that anyway? What does it look like? Have there been programs that have been implemented? Are there pressures that are currently being put into place, or is it also business as normal for international actors as well?
Do you want to start on that?
Shall we take?
Yeah, sorry, yeah.
Again, just because there's a lot of people who want to ask. Yeah.
Thank you. The first task force that was established in order for preparedness in Sierra Leone, did it involve any social scientists or anthropologists? And with regards to the burials, how was it handled, all that death? The safe burial aspect was mostly handled by MSF, but in your respect, how was it handled? And with regards to integration, the main complaint was how various NGOs were not integrated. How did you tackle that? Like, were there some recommendations in the future, especially with the current Ebola outbreak in DRC?
So what do you mean by the word integrated, sorry?
The integrated effort in order to tackle
Working
Involvement
together,
of
okay.
civil society.
Okay, fine.
Okay, is there one more in this round? Yeah, Abbas.
Thanks very much for your presentation and talking about experiences. For me, working on zoonotic disease in a different context, there was a lot of learnings for me, especially given the fact that I always understood contrasted response to outbreaks as being much more proactive, much more quicker, and much more agile, as opposed to responding to peacetime and neglected zoonosis. So this was an eye-opener for me that if this can happen to Ebola and Sierra Leone, then things for the zoonotic disease might be even worse. Expanding on this theme, my question relates to the fact when you mentioned that on paper in the checklist, you know, all the health systems and preparedness plans seem to be in place, but in reality things were not like that. And reviews of pandemic preparedness plans by Richard Coker and his group in different continents and other studies have shown that, you know, because of the self-assessment involved in pandemic preparedness plans and IHR checklists, something similar might be happening in many other countries as well. Are you involved in any discussions post-Ebola about what's the state of these checklists and their implications on global health security? Thank you.
There is. Start on HSS.
Yeah, I mean, I think there have been some shifts. I think the Sierra Leone, I can only speak for Sierra Leone. I think the Sierra Leone government has prioritized health more now, relatively, not massively, but a bit more than it had. But in particular, it's passed some important legislation that enables it to do things like specialist training of surgeons and things in the country.
Surveillance.
But the big thing is they've restructured the CDC, US CDC in particular, has done a lot of funding on a bit around infection control, but mainly around surveillance. And they've got surveillance officers, community health workers, dialing in a list of diseases from every primary healthcare clinic to a surveillance team every month. I think the problem is that is, and there's also been a big focus on labs. So there's been a massive lab strengthening effort. My concern is that is, it's sort of falling under this global health security kind of concept now, which I'm a bit anxious about because I see it as quite a colonial model and one that says, how do we in the West protect ourselves from Africa? Rather than saying, how do we support Africa to develop effective basic health services? And therefore, surveillance and labs are things that you need to protect Britain from an emerging infection. Sierra Leone, they're not particularly helpful for a kid with pneumonia, you know, in a village somewhere. And therefore, I think, and it's sort of just another vertical program. In terms of our priorities, there's been some quite infectious disease-specific programs, but they're still going in at that angle. and others might know more. I think my other concern is that the way it's being done, I was looking at so my PhD is on leadership development of early career doctors. There's a program out in Sierra Leone. It's, as far as I can tell, being run out of a hotel conference room. It's a one-off. It's all foreign faculty. People are being paid to show up. It's not going to be repeated in future. All of these practices that don't need any kind of lasting capacity or any kind of, kind of bottom-up approach. So it looks quite like business as usual, but with this global health security mindset. Anything you want to add on?
No, I mean, I suppose on the slightly more positive side, I think these kinds of learnings can, as somebody who works for a donor agency and has for the last 10 years, they can create space for individuals to do things differently. So one of the reasons why we're keen to do this presentation as we did the other day in DFID and Irish Aid, and we did it in OFTA in the US, is because when these lessons, obviously not just written by us, but written by some of you in this room and others, they can for somebody working in a donor agency, they can be something that you can use in a proposal, and you can say, well, we all remember the big lesson from, and it can create some space for individuals who work within those agencies and believe this stuff, to actually get others to say, oh, yes, absolutely, yes, we all remember the West Africa and the health systems and the governance and so on and so forth. So I think that's one of the reasons why we need to talk about it. It doesn't mean that it's going to automatically happen. And as Oliver says, we have big flaws. I mean, our sector is very flawed. I believe, and I wrote a whole PhD about it. I think we need to recognize the limitations of the aid sector. And I mean, I suppose I would certainly be somebody who, although I have spent my entire career and all my studies looking at the aid sector, that would feel as though, really it has very limited potential. The changes that are really going to be significant in countries like Sierra Leone will be made by Sierra Leoneans, will probably have a lot to do with the private sector, will probably have relatively little to do with the aid sector. So let's also be modest in our aims and try to do the things that we do well. So for me, it's also it's a bigger issue. I don't know how I got over there.
And do no harm in that as well.
And do no harm.
Yeah,
Number one, do no harm. Yeah.
You asked about the task force. Did it have any social scientists on it? No, so it was UN agencies and humanitarian NGOs that turned up with Sierra Leonean colleagues. I think one of the things one of the debates around the role of anthropologists in the response when we were getting interviews with people is some said, do you need anthropologists or do you just need Sierra Leoneans to be more part of the room? And I think the truth is a bit of both, but I think one of the challenges was the Sierra Leonean colleagues in the room, there is an elite in Freetown that can be quite distant actually from what's going on in rural villages and some groups. And Sinead talked about how marginalised Kailaun was. I remember in the first meeting we had after Ebola was diagnosed in Kailaun, and there was a conversation around what are the roads like in Kailaun, and the minister said, has any of my staff ever been to Kailaun? And none of the Sierra Leoneans in the room had ever been to Kailaun.
I have.
So it was actually the NGO workers who was part of their project, and so part of the challenge was not only that we didn't have an anthropologist in the room, and I wish we had, but also that that there was a disconnect sometimes. People felt like, well, I asked a Sierra Leonean and they said, and
therefore I'm off the hook because I asked a Sierra Leonean. And I think this is one of the things that we tried to point out in the book, that internationals can't get off the hook and say, well, I've looked at participation because I asked somebody from that country. We all know how incredibly different parts of the country will be, how we can all have our own biases and so on. But I think, your question is important because, and I mean, Annie and others will know more about this, how the regional context worked out. But I mean, we understood that there was an anthropologist sitting on the National Response Task Force in Guinea, but not in Sierra Leone. And I think one of the challenges, I mean, the stuff that the anthropology platform was publishing and stuff like that, like I loved it. It was very much along my kind of lines. Frankly, very difficult to get the time to read in these kind of responses. And I really do wish we'd had more physical presence of anthropologists during the response, because there's something about somebody being in the actual meeting where the decision is the expert themselves, not just somebody who has read something the expert has written and so on. So I mean, it's something you guys might want to talk about how you saw all that. But I think when anthropology was influencing the response, which was a lot of it was sort of towards the latter part of the response, it was so valuable. And when I would have time to read something, by it'd be so, I'd be like, God, I wish I read this 6 months ago and so on. But it's about how that was being done. I think it could have been even more effective if there'd been more people, and if we had gotten the people in the right rooms, to be in those task forces and to speak as experts directly. And I mean, you guys may have thoughts on that, but the burials. Yeah,
I mean. One thing I will say is that, again, I did not handle, I wasn't involved in burials, but I was involved in dead bodies. And again, in the operational context, there was not a lot of dignity, certainly at my unit, not for lack of trying, just for lack of space and lack of resources. But again, we didn't prioritize it, and it proved to be a big issue. But Sinead, do you want to talk more about what we did do?
Burials, yeah. Burials started off really badly and got better, and I think this was one of the areas where anthropology was helpful. Actually, most of the burials were done by actually Red Cross and local volunteers working for Red Cross, working for Concern, and so on. And initially, it was so badly done. And I mean, one of the villagers that we quote in the book, in the early days in Kailaun, he said, it's like my relative is being thrown away in these black plastic bags like rubbish. And just imagine how that was, and then they wouldn't be able to attend the funeral and all this kind of thing. It was very much the sanitized burials. It did definitely improve, and again, it comes back to this, the whole notion of compromise, and and sort of the workers and the community members sitting down and saying, okay, how can this be within the limitations? How can this be as the least worst kind of scenario? And so eventually you could have relatives at the funeral as long as they stood 10 feet away. You could have an imam or a priest, again with the, so these kinds of things definitely improved. But again, it was one of the things that led to more infection initially, because we were doing it so badly that people were like, well, the last thing we're going to do is tell the response that this person has died. We're going to go off into a corner, bury them, end up with more infections. The NGO coordination question, I mean, the main point I would make about that, I mean, Oliver already mentioned, a lot of NGOs just really didn't know what to do with themselves on this response. There was so much fear of Ebola. A lot of people evacuated and thought, this is not for us, we're not medical, and so on. And the NGOs that really made a difference were the ones who basically said, we're here, we don't know anything about Ebola because nobody except MSF knew anything about Ebola when it all started in West Africa, but we're ready to be tasked. And I think those were, but unfortunately, and we've spoken to a few of the NGOs who we don't think did so well, and a lot of them have actually admitted that they also don't think they did so well. But coordination was really poor, and just really briefly, one of the big reasons that coordination was so poor was that we refused to treat this like a humanitarian crisis. We were treating it like a health crisis, which was actually a political battle within the UN, so that WHO would take the leadership. So I was sitting there puzzled going, but OCHA, the Office for Coordination of Humanitarian Affairs, are supposed to be here to do coordination because this is a humanitarian crisis. And I was told, no, it's not a humanitarian crisis, it's a health crisis. And I was like, that's not actually true, it's both. So this is one of the things they're also looking at now in Congo, is how can they not have these silos. The last question.
I'll just add one thing on the. So at the Freetown Command Centre, suddenly as the response emerged, all of these new Ebola units started popping up, and MSF did some really good work. But you might have noticed on that whiteboard, we said the bed capacity of every facility except the MSF one, which had a question mark next to it because they wouldn't tell us how many beds they had. So that was, we were trying to coordinate, but there were different attitudes towards that within organisations. One of the things we did, so for example, one of the units we had to try and work around was the Chinese military deployed First time they've ever, I think, done an international humanitarian deployment before. They ran an Ebola unit in this walled-off Chinese hospital. It was a bit of a black box what was going on inside. Very few of them could speak any English. We had patients at Connaught who had broken out of their rooms at the Chinese hospital, scaled the wall. These are Ebola-positive patients, scaled the wall, got in a taxi, come to a hospital and asked to be admitted because they were so upset about what was happening, the care they were receiving, or communications, or whatever it was. So we were trying to work out how to make sense. You can imagine the politics that was going on around this. One of the things we started doing is doing every week a scorecard of units. So we were trying to make sure patients had better quality care, better safety, and had a faster throughput of patients. And so we did a scorecard and we ranked them. And the first time we ranked them, the Chinese came bottom, and they got wind of this, and they were horrified, and they published a paper, they talked from their side about how they immediately called an all-team meeting, and the next week they came second, and they turned up to every single coordination meeting we had from then on. And it was amazing how a little bit of publicity, whether they wanted to be coordinated or not, led to a much more engaged response. So yeah, that was an amazing lesson for me in terms of responding. The last question was
preparedness checklists.
Yeah, I mean, so Sinead disagrees with me on this point. We talked about it last night. I think my experience with a lot of DFID grants is that they are quite checklist oriented around outputs, even though they talk about theories of change and outcomes. A lot of the stuff I've had to submit for my grants has been how many people attended a workshop. And so my experience is a lot of the way aid has set up has led us towards that. Sinead has more donor experience. I think she thinks that I'm being
I think we know. I think we all know. The difference between outputs and outcomes, and there has been more emphasis on outcomes and all of that kind of thing. But I think one thing we do agree on is that the whole focus on results-based management the last kind of 15 or 20 years has definitely is definitely often quite limiting and again leading to this sort of short-term, what can you tangibly show us kind of focus. But I mean, obviously DFID is enormous, right? So they do all sorts of things, and some they get it better sometimes than others.
But two examples not involving one is I remember towards the end of the response, someone from UNICEF came with a clipboard and he said, we want to work out how much the hospital at Connaught has been affected. We're doing a national health survey, how much the hospital is currently affected by Ebola. How many beds have you currently got open? Has it reduced your clinical output for normal diseases at all? And the medical head of the hospital said, no, we're fully open, it's completely as normal. And the guy ticked it off and went away, and you go to the wards, they're empty. Staff on strike, the wards are empty. But the process of actually working this out was a very simplistic checklist. And similarly, the data that was coming out of the hospitals was an order of magnitude wrong. So I think the quality of some of that data, and yet a lot is then later on, a lot of decisions are made based on it, but a bit of a sense check around, and you don't know if you want to comment about your infectious, your guy who came to Connaught looking at our procedures and...
It's actually kind of quite relevant to the question, I suppose. So there was a WHO guy, who was a kind of senior microbiology professor, and he came kind of towards the end of Ebola, and he was asked to come up with a preparedness, manual for Sierra Leone on Ebola preparedness. And I said to him, you should chat to Oliver and go along to Connaught and so on. And so then I spoke to him the night after he'd been with Oliver in Connaught, and I said, how did you get on? And he said, well, I'm not sure they need a set of guidelines. They definitely need soap, And I was like, yes, that's exactly the case,
And just to add in that, they need soap, but presumably preparedness also means the things that you had in your list, 5 at the end, which are not in the checklist of the International Health Regulations.
No, it's true.
So preparedness plans and preparedness checklists are not talking about community relations and engagement, leadership capacities, politics and accountability, working through government systems and the roles of individuals. These are almost by definition, they're not quantifiable, they're not on the IHR list, and yet aren't they critical, as you've shown. So, fascinating. So I think we're really out of time. Has anybody got one more last quick burning question? Yeah, okay. You can have the last one, and then you just respond and any last words you'd like to have.
My name is Sam. This is for you to do a little PR. I want to talk about the book. I saw in one of the slides you referenced Paul Richard. I read his book on Ebola. He published it in 2016, and he was a little bit critical about how the international donors and agencies handled the Ebola situation. So I just want to know if does this book, Getting to Zero, is it also as critical in terms of the work, or is more of a self-appraisal?
Yeah, I've read Paul's book. He's a friend of mine. I'm actually on the cover of his. I'm one of those people who endorsed his book. Yes, I think our book actually focuses a lot more than Paul's on the performance of different agencies, because his, as you know, is mostly focused on the sort of the anthropology and the community relationships aspect, which of course is a big issue for us, but we also sort of look at, you know, issues around coordination, how the response was run and so on. So I think, I think one thing, maybe if you're British or you're particularly interested in the UK, I think one thing, WHO, everybody's criticized WHO. This is not something we consider particularly innovative in our book at all. And in fact, we deliberately don't spend a huge amount of time on it because it doesn't need proving, right? WHO are admitting it as well. I think one thing that our book does, which hasn't really been done, is really look at the British response, because it was the big response in Sierra Leone, and it has gotten unbelievably little scrutiny, I would say. Including within the British government, as far as we have been able to access. So and we hope that's a useful contribution, because you're talking about, you know, £1 billion or £2 billion, thousands of staff, and so on and so forth. And so we think that, you know, even if you're overall saying something was a good thing, and we do believe that it was imperative that the UK government came in when they did and really had a big push, you know, it can be a good thing and yet have a series of things which we would hope they would take into account, and others would take into account, you know, the next time. So that's probably one sort of area where we maybe, but we kind of criticize everybody, including ourselves, because we all did mess up, frankly, you know, and so, you know, and there's loads and loads of heroes and people, and particularly organizations that messed up and then improved. You know, that's exactly what we should be, and we give credit to WHO for you know, they're so much better now in Congo. Not that Congo's going well, huh? But it's not for lack of WHO really making important organizational changes because of what happened in West Africa. So, you know, it's this balance of yes, there's no question it's a critical book. It's critical of the government of Sierra Leone, it's critical of all sorts of people, but it is important to give credit where it's due as well, because, you know, we all need to have some path to hope that we can all do better.
And I think just to add on, just to add on that, I think one of the things we try to do is support those with our own direct experiences and tell a very specific instance when we experience that thing. So as well as supplementing with, you know, references to data and interviews, we tell a very specific story where we had this issue that kind of gives it I hope will make it more memorable. We want it to be an easy book to read, but full of anecdotes that you will remember years later because they're quite human. But also it's, you know, linked to, you know, mainly Sinead did most of the heavy lifting on 200 pieces of literature and everything else. And so we wanted to try and get that balance so that it feels quite human. And I hope if any of you read it, you find the same thing.
Absolutely. Well, look, thank you so much for sharing both the process of producing this and some of the key messages. I mean, I think, if anything, Ebola has been a learning experience for, I think, everybody who it's touched or who has observed it in many ways, and if one can take something hopeful and positive from this horrible crisis, it's that actually things will get better. So I'm pleased that you've kind of drawn out some of those lessons and ended with the slightly more hopeful messages. I'm certainly going to go away and read it. I think this is also probably, this is for another day, a kind of really interesting experiment in writing, and we talk a lot in development studies about narrative and the importance of stories and personal stories in engaging with policy and practice and so on, and I think it's probably well worth reading.
Well, let us know what you think, because it was really hard.
Yeah, I bet.
Really hard to write. So hopefully,
really interesting.
Hopefully less hard to read.
People from different backgrounds. So, I think. Wonderful. Join me once more. Let's have a big clap for Sinead and Oliver.